This is an anterior segment OCT study done just before femtosecond laser treatment. And you can see the green line there. That's obviously the anterior surface of the crystalline lens. And it is bowed forward, namely it is convex. And that would be clearly visible, especially with a dilated pupil, at slit lamp exam. And that shape, anterior capsule, that indicates potential danger of capsulorhexis runout into the periphery during a manual capsulorhexis, the so-called Argentinian flag sign. And that's why in these lenses, and they're typically mature white cataracts, we strongly favor doing femtosecond laser capsulorhexis. Here we see that eye immediately after the performance of the femtosecond laser capsulorhexis. And you can see the outline of the edges of the capsulorhexis in certain areas, but in some areas it's not clearly visible. So I prefer, and I'm about to stain the anterior capsule with trypan blue in order to best see the outline of the capsulorhexis prior to removing the anterior capsule. So I'm going to begin the procedure here by using a side port blade to make an opening. That's a little more than 1 millimeter there. And now the 2.4 millimeter temporal clear corneal incision. I'm going to wiggle there to get in slowly. Now I'm going to stain the anterior capsule with the trypan blue and then a little lidocaine. And now I'm injecting visco to fill the anterior chamber, and I want to go distal and expel the trypan. You can see the capsule folding up on itself and coming toward the incision, but it doesn't look like it's free. So I got to be sure it is, so I'm going to inject visco distal to it and centralize, if you will, reposition that capsular flap. And now, very importantly, don't pull it out of the incision. You go in and squeeze it centrally so that it collapses on itself and tears toward the center. And now we're pretty sure we won't get any so-called outies, micro tears that go out toward the periphery and would be weak areas that could split. So here's a hydrodissection and now visco dissection. Again, using visco here. And now as we proceed to phaco, it's a dense nucleus, obviously. I'm going to use the Mackool curved big ball chopper and put in the phaco first and then increase IOP so I can get it in. Quadrant. And I'm using quadrant removal to remove some loose cortex and get a little better view of the nucleus here. And now on sculpt mode, I'm going to put the chopper out over the equator as soon as I make a little bowl here in the center. And I want to get a vertical sculpted wall. That'll be obvious why later on here. So now I'm holding the nucleus still with that chopper out over the equator. And that lets me make better progress because the nucleus won't tend to move away from the phaco tip. And I'm sculpting deeper and deeper, but you can't sculpt down to a red reflex here. You'd be almost down to capsule by the time you got one. So once you get pretty deep, you test the waters. So as soon as I get a good sized bowl here, and I'll do an impale chop. And I'll be using about 300 of vacuum here. Hold the nucleus still on position 2 and divide it. So I was deep enough. If that didn't chop, I would go back and sculpt deeper and do it again. So here we go. And that time I didn't even have to hold it still. So let's try and get this segment out. And it's wedged in there, so I'm going to go behind it with my chopper and move it centrally just like that. And you can see that these procedures, they're not going to be real quick. They're going to take a little bit of time. So here we are again. But here I didn't even have to impale it. And let's see, I might try and impale it here and hold it. Yeah, good. So quadrant. Now we'll go ahead and remove these segments. That's a pretty big one, a little more than a quadrant, but. And here I want to pulse my foot pedal. I just don't want to buzz continuously. So I wait for vacuum to get high. Here I'm impaled, so I'm came off and go to another spot. Now listen to the vacuum tone. There's a little bit of a floppy iris here, but not bad. So what I'm doing here is hitting the pedal when the tone goes up, then coming off it as tissue cataract disappears, and I do that repetitively, and that's pulsing the pedal. I'm going to loosen the speculum. That'll reduce the tendency for the globe to collapse and iris to prolapse. And I'm going to go in with the INA tip and remove the cortex that's here. Most of these eyes don't have a lot. And there's a little piece of nucleus over by the side port. So I'm going to go get that, push it in with the spatula. And remove that cortex. Then I'm going to remove some epithelium from underneath the anterior capsule here. And just by vacuuming. And that's low vacuum, only getting up to about anywhere from 50 to 150. So now that capsule is pretty clear, the anterior capsule, nasally there. So the little tendency to iris prolapse, not bad. Little OVD here, filling up the capsular sac. Posterior capsule is pretty clear. So we're going to go straight on into IOL insertion. And now I can open the speculum a little bit more, so a little better access and get it out of my way for my second instrument there. Well, straightforward IOL insertion into the capsular sac. See a little bit of fluttering of the patient's eyelids, but not enough to matter. And I'm going to let that unfold into the capsular sac there. So back to INA, going to remove OVD, nudge the IOL to the side, and slip that 90-degree angulated tip under it, the IOL. The 90-degree does that so easily. And I'm not going to remove OVD from the anterior chamber with the INA because I'm afraid the iris would prolapse. In this eye, it's got a little floppy iris. So I'm going to do stromal hydration, seal the incisions. There's a little piece of nucleus. I saw that earlier floating around. We'll get that to flow out of the eye as we irrigate out the OVD. And this, we have a less chance of iris prolapse doing it this way than if we use the INA tip and then suddenly withdraw it. Here I can keep infusing into the eye with the syringe as I back out and keep the iris from prolapsing. Okay, so a little more OVD removal. Continue to inject BSS as I kind of back out of the eye. IOP is nice, feels solid here. We'll check the incision just to see there's no leakage. Those red blood cells are a nice little Seidel test. When they go across like that, you know you don't have leakage anywhere. So that's it.